Good morning, everyone. It's my distinct thrill and pleasure to welcome you to the 10th annual Connected Health Symposium. 10 years ago, sitting around a table, Joe Turnello, who was really the person who came up with this idea, and it was a germ of a concept that's grown into an amazing, flowering, beautiful tree. And so we really want to celebrate this year with all of you. My task this morning is to be brief and get out of the way so we can hear our wonderful speakers. So I really only have two things I want to say before I introduce our CEO, Dr. Gary Gottlieb. The first is to please give a warm round to our symposium staff led by Deanna Grossbaum. They've done an amazing job. It's no small feat to put together a meeting like this and have it run like a Swiss watch, and that's really what Deanna and her team have done. So all the way down to the AV support, everything is really homegrown here, in-house, not outsourced. So we really, really appreciate the team coming together for this event. The second thing is you all have a placard, or a place card rather, on your, in front of you or on your chair for Wellocracy. Please go by the Connected Health booth. There's a lot of interesting stuff coming out of our center in the last year. If you were here a year ago, there's a lot of updates. Please visit folks at the booth and get those updates. But Wellocracy is something I wanted to turn your attention to. We're launching it today. It's a really exciting effort for us to get into the consumer health space at the Center for Connected Health and educate and inspire consumers to use self-tracking devices to improve their health. So please stop by the booth, go to the website, learn more. Most importantly, give us your feedback because it's a brand new endeavor and we really want to shape it according to your feedback as well as others. We're really excited about that. Well, again, without further ado, let's get on to the wonderful content we have for you. The first speaker is our CEO, Dr. Gary Gottlieb, and it's a real privilege to be able to introduce him. I've been at this business of connected health now for about 19 years, so I've had the privilege of working for a number of CEOs at Partners, and Gary is very, very special in his support of the vision of our center and the work that we do. And I met with him a few months before he took the reins as CEO, and he said to me, Joe, there's no question that the kind of work you do at the center is going to be front and center in our future of healthcare delivery. I said, I don't really need the rest of the meeting. So it's been a privilege ever since to have his support of our work. He's going to talk about some really important work being done at Partners on patient-reported outcomes, and I don't want to steal any more of his time. So without further ado, please give a warm welcome to our CEO, Gary Gottlieb.
Thank you, Joe, and thank you, Joe. But more importantly, thanks to all of you. Thank you for coming and joining in this conference, for sharing your thoughts and for sharing your work and for sharing your ideas about really how we can improve healthcare delivery, how we can improve the state of the way, not only that we deliver care, but the state of health and the way in which we treat illness in this country. That is clearly a deal that you have made together with society and with us. And in the work that's being done in connected health, we have true translatable solutions that will allow us to provide a greater degree of efficiency, a higher degree of patient-centeredness, and to truly be able to meet our mission in a much more formidable way. So I really do thank each of you for the work that you're doing, for the interest that you have, and for the opportunity that the work that you will do will create, not just for us collectively within this community, but for society. This is certainly an interesting time in healthcare. The talk that I'm going to give today really, I think, talks about how we are trying to leverage major issues on the connected side to improve outcomes in healthcare and for us to be the underpinnings of our strategy. And it really reflects the work of a brilliant young physician, Neil Wegley, and his team in our population health management group, and an extended team in patient outcomes and safety and measurement across the Partners healthcare system. This is work that we are investing in because we perceive that it is a vision to truly engage our patients in teaching us how to improve healthcare and in allowing us to truly measure value. The demands on the healthcare system now are for us to be accountable, but the accountability can't be about price. It can't be about transactional outcomes or even total medical expense. It has to be in the value of what it is that we deliver to society. And in measuring value, the outcomes that we must be able to measure have to be those that are relevant to patients and those that inform our individual physicians and other providers and inform the system as to how to improve itself. And with this work, Neil and his team are leading us on a pathway to improve ourselves, to learn, and to humble ourselves in the way that we deliver healthcare overall. Just to remind you who it is who invited you here and who you're participating with, the mission of the Partners Healthcare System and the reason that we're making this investment and the strategy to try to transform the way in which we deliver care is one that we find to be precious and needs to be nurtured and protected by our strategy. It's to try to figure out how to bring the best and the brightest people to provide care for the sickest and neediest populations among us. How to use the science and the tools of discovery to improve that care, and how to use care to truly inform discovery. And that is a challenge we have. We're a large R organization. We have $1.5 billion a year in extramural research funding, but it has been driven in traditional academic ways. And our ability to translate that research into ways in which we can improve people hasn't been the driver of the way we've worked with investigators. So to have you here and others to help us to achieve that mission is pretty critical. And we are, like most other academic institutions, can only be judged by the quality of the work that our young people do and we do for them, and to nurture them. That pipeline of young people is the future of healthcare delivery and science, and we've been in that business for more than 200 years. And finally, we are committed to our community. That's the rent we pay for the privilege of doing this work. And our communities are in Mission Hill and Roxbury, in Charlestown, Chelsea, and in Rwanda and Haiti and Lesotho, and in Durban, South Africa. So on the clinical side of what we're trying to do strategically as we transform the system from one that is focused in fee-for-service medicine, has been quite transactional, to working in teams, managing populations, and moving from an illness care system to a healthcare system, our objectives remain the same, and that is how to improve the human condition, how to provide the best possible care to the people that we serve, to make certain that what we do is appropriate, to do it in the best way possible, and to truly try to figure out how we avoid redundancy or inefficiency in that process in a way that we can be accountable to society so we don't crowd out the other elements in our inefficiency. And in that regard, we need to know, how do we learn from our patients? How do we learn from the transactions that we're engaged in constantly? And how do we learn which are the most appropriate interventions for the conditions that we're delivering with? Clearly, we have been committed as rescuers and as the heroism of healthcare delivery in trying to figure out how to save lives. That's something at least we can measure, or measure in pretty gross ways, how it is that we avoid mortality, how we reduce morbidity overall. But in terms of the overall measures of quality of life and looking what it is that our patients and society is looking for, it has been somewhat more elusive in terms of that measurement, and in allowing the patient to have voice, and having voice in a way that has test, retest reliability, inter-rater reliability, and has data that can be validly used to be able to inform the science that we have, and that can change the way that we practice medicine. So we believe, and this group is focusing on the notion that the outcomes and the measures that we have, and the way that value and providers are being compared at the moment, is a set of pretty dull process measures. They can't really articulate differences in providers, and they don't allow us to look condition by condition, experience by experience, or patient by patient, and practice by practice. So patient-reported outcomes, we believe, are a pathway in this regard. But the patient-reported outcomes just can't be analog. They can't be provided in such a way that we can't use the data, that they can't really populate our data warehouses, our data marts, and be able to inform our decisions overall. They need to be able to be quantified, they need to be trended and aggregated, and we need to move away from pencil and paper approaches where we can hear a little bit of voice, and frankly, we need to move away from subjective material that can't be compared or scaled overall. And that's why we believe we need to use validated tools, patient-reported outcome measures that are used in a consistent way, that are interpretable and actionable, and that can also be collated together in the same kind of data repositories that we're using for other sources and other measures overall and across our system, and then to be scaled so we can be compared to other institutions. We believe that it is part of our mission to be able to develop these tools. We believe that it is critical to our strategy to use these tools to demonstrate that the way that we work is in fact better and has value, and justify frankly, whatever premiums we need to charge to be able to provide the best care possible in the marketplace. So, and I apologize for this slide being older than Tuesday, because I think that this device is just a little too thick and too heavy. But the next generation of platforms, and this is not an advertisement for one of the tablet companies over the other now 17 that exist in the marketplace. But the question is, how do you make something that's friendly? How do you make something that's, that can be appealing to a 6-year-old who's in a child clinic or to my 90-year-old mother, and make it useful enough? And be able to stay connected over a period of time and do it in a way that's thoughtful and efficient. And so the interface using a tablet for us in clinics and being able to follow up telephonically or on desktops or laptops creates an environment and an ecology that we believe that we can continuously nurture and improve, and use the great work that you and others in the community are using to make those devices and materials and ultimately data repositories more and more valuable. Again, let's go back to the key point, and that is that we need to have a voice for our patients, but the voice needs to be something that can be replicated. So we need to use tools that have construct validity, that have been studied well in terms of inter-rater reliability, and that the field accepts. So those who work in rehabilitation have to embrace the work that we're doing on functional status overall. Those who are focusing specifically in heart disease and function and quality of life, or in pulmonary disease, or in orthopedics, or in sexual health and other areas. We want to use tools and measures that have been validated in the specific areas so that they'll have credibility in the provider community, so that they can be replicated and scaled in our overall community, and that we can use and translate those data relatively well. And the same thing on the behavioral health side, where the components of what we need to measure are critical each and every day. When Joe introduced me, he didn't mention that I'm a psychiatrist, so my bias in presenting the ways and our deficits in that regard is probably great. But now that we've moved collectively as a society to looking at population health management and in trying to figure out how we take care of the sickest among us, those 10% of the population who consume 70% of the resources in Medicare, or 5% who consume 50%, we now understand that the ways in which we have essentially filleted the behavioral health system in this country has made those expenses more real, and that we need to reinvest in ways to make that care accessible. But we need to know when it's necessary. So the kinds of questions that we're delivering are the ones that at least our patients are starting to tell us that they want to hear about, and our physicians are telling us the same thing. So let me give you an example. The names of the patients have been changed to protect me and the innocent, but these are real people who are facing real challenges within our system, and patients whom we are failing, because despite the fact that we have the most magnificent providers who are providing the most extraordinary transactions in their interactions with their patients, our ability to both work in a continuous and ongoing way because of the way, frankly, we've been paid and the way we've been organized around silos, and the data that we have are incomplete and therefore haven't informed us adequately to be able to provide the right care at the right place at the right time. And in a way that I would say as a psychiatrist is truly accurately empathic, which is what our goal is as providers and helpers in all of our venues, regardless of our discipline. So this patient, Mrs. Lovell, we'll call her, is a 60-year-old woman. She has a history of treated and stable endometrial cancer. She's morbidly obese, and she was diagnosed this spring with diabetes. She's been in many different venues in our system, seen by multiple specialists in a way that's not at all unusual for people who have complex medical diseases, and she has intractable pain. Her quality of life is quite poor. She thinks about her pain before she thinks about pretty much anything else that's in her life. And that has brought her to the emergency room. It's brought her to the easiest portal to get to in our system, and that's the one that's available 24 hours and 7 days a week, where nobody asks questions before you walk into the door. And she has also used a set of ancillary facilities. I would tell you that if you look at the bevy of physicians that she has treating her, it's the same group of people that when most people call my office and ask for an appointment, the unfortunate way in which too many people have to get their health care organized by us and for us, these are the people I would refer any one of us to and want my own family to see. But in some way, there's been very little progress, other than the acute intervention around her endometrial cancer or the identification of the specific diagnosis in terms of her care. She won't, on a regular basis, check her blood sugar. She seems not to be able to lose weight. She can't seem to get control over the pain that she has. And if you think about her morbid obesity, the role that plays in her osteoarthritis or her degenerative joint disease and the pain that she has associated with that, obviously it's exacerbated. And if you look at across the system, she sees providers from a variety of different specialties in a number of different doorways who are barely speaking to one another. And we have an electronic medical record, and I can tell you that an electronic medical record, unless essentially all the right questions are being asked, becomes just like a big, thick paper chart. All the data are there, but it becomes very hard to seek and find the outcomes unless they're connected in a way that makes a lot of sense. And we have tools we've been working on for that as well. So she's been a Partners patient since before Partners was even a dream. Before the last iteration of healthcare reform, before Mrs. Clinton put forward healthcare reform in the 1990s. And she was morbidly obese back then. She's had hundreds of encounters and hundreds of notes across our system. And in a continuous way, she has had significant problems. And she readily answers that she has clear mental health problems. The best doctors have seen her in an ongoing way. So how many visits over this period of time has she had with a mental health professional? A psychiatrist? None. Therapist of any kind? None. A social worker? None. How many times were the words depression or anxiety in her chart? Depression? None. Anxiety? None. And how many mentions of mental health in her notes in any way? None. So the principle in PROMS is we have to figure out how to ask the right questions. And we have to ask them for the areas that we're targeting in order for our patients to teach us how to deliver care, in order for them in a quantifiable way to help us to improve the system that we have. So we have a validated measure that I can tell you as a psychiatrist we use in studies and following and trending populations overall. And we have to decide together what the efficient interval is in terms of screening based upon what the disorder is and informed by experts in that field. We need the answers to go to the right clinicians so that they aren't just sitting and hanging in a data set in the same way that it's urgent that lab data get to a provider who has tested those data or radiology data. These data need to be sent to the right provider at the right time. And we need to monitor in some ongoing way. And for us, we use the web, and I said, in the phone, to be able to monitor, to understand what the relationship is between symptom severity, the treatment someone has, and the availability of those treatments overall. And in using our PROMS approach, we ask specific questions around the detailed areas and ask those people to be able to measure them in terms of their severity in an analog way so that they're able to put together those symptoms with some severity index overall. And if you can take a look at her care, this is the hemoglobin A1C is a measure of the control of her diabetes. And if the goal is 7, you can see that in April of last year, she was significantly out of control with a level that would worry any of her providers that she was out of control and she was at risk for significant chronic disease outcomes overall. And over the course of time, as her depression was treated, basically her visits to other physicians, her emergency room visits diminished to 1 visit over the course of that period of time. She had a fall, which is a severe outcome measure, a severe and untoward outcome associated that she's at risk for because of her age, her osteoarthritis, and her obesity, but her outcome is remarkable in terms of the improvement of a different measure, not the measure specifically of her depression. And this isn't, don't worry, this isn't just the things I'm interested in. Let's take other disorders as well. This is a story of a different person, of a mid-60s retired police officer who has had an ongoing anomaly that was diagnosed many, many years ago, identified when somebody heard a heart murmur, and that he had a bicuspid aortic valve. He's known to have abnormality in his aortic valve in such a way that it's basically closed down and allows less flow in a way that is dangerous for him. He is a stoic. And he really does not really want to share his symptoms with anybody. He thinks that is, I think, a reflection of who he isn't, as opposed to who he has been over all time, like many of us. Remember, there are clear cultural and personal differences to the way that we each bring our life to the table in our workplace. We certainly bring our illnesses to the table. So PROMS asks specifically about chest pain. If there's no chest pain or just very little chest pain, it's okay. And chest pain is a critical symptom that's associated with aortic stenosis and when it needs to be intervened with. And when we asked him these questions as part of the ongoing monitoring that we associate with the risk that he has, in every one of those, he had symptoms that are significant and significantly associated with aortic stenosis at a level of severity. And I would assure you that if this weren't Frank and it would be me, it would probably be 3 or 4. But that's just a measure of my being culturally a kvetch, while Frank is culturally a stoic in that regard. I'll interpret kvetch for you later in the question section. If you look at the natural history associated with bicuspid aortic valve and aortic stenosis, symptoms really show that one starts to reach a cliff very, very rapidly. So when somebody goes from being asymptomatic to being symptomatic, the risk of an untoward outcome and or death or severe cardiac outcome becomes extreme over time. And this is one of the areas, and I'll say it to the surgeons in the room, in which surgery actually is curative. And those of you, I don't want to argue with any of you who are surgeons. I do believe that surgery is a cognitive discipline as well. But surgery is only appropriate, and it's a major intervention if, in fact, symptoms are there. So in the absence of our having asked him these questions, in the measures having stimulated with what are associated and accepted across the discipline as reliable and valid measures, we wouldn't have asked him the specific questions overall. His initial PROMS, in which he showed those symptoms, was on August 17th, and he had the surgery 4 days. So 4 days later, so we were able to intervene because we had the data in a way that was curative for him. It caused a resolution of his chest pain, his functional status improved overall, and his mood and social functioning improved as well. I don't know whether he became a complainer afterward. I didn't have a follow-up specifically in that regard, but we'll know every 6 months as to what he's complaining about. So, you know, first of all, this is it's impressive. It's impressive in a way that informs the way that we practice overall, and it's a predictable functional outcome. One has to say these, in both cases, are the outcomes our patients want, that are meaningful to them, but they're also critically meaningful to our practitioners, and they inform us about what to do when in a way that the ordinary approaches to measurement don't. And if this were not connected, if this were not automated, we wouldn't have data repositories to help us to inform our practices and how to improve them. So for example, when we looked across clinics in this regard, one clinic had consistently better chest pain scores in the post-operative period. Not in the preoperative period, where essentially the complaint was a predictor as to whether or not there might be an untoward outcome. And when we looked clearly from clinic to clinic, the initial investigation suggests that it might have been related to chest wall pain, not to cardiac pain that was related to the surgical wound. And so the question is, how do you look across each of these clinics, use data, and use interventions to be able to make a difference, and then to use the positive experience in that one clinic to inform and to improve the care in those other clinics. And that's what we need to be accountable for. And without that knowledge, without that ongoing way of being able to use those data, without making this friendly to our patients in a consistent way, and without using tools that Neil and his team have brilliantly brought together to be able to inform this process, we would be lost, and we have been for a long period of time. This is on our shoulders, and for us, this is a critical tactic in our strategy to improve value overall in the system. To just put kind of a cap on it, patient-reported outcomes are critical to inform the way that we provide care. They capture some of the stuff that's most important to patients and basically gives our patients a voice in a constant way as to how we should be delivering care. We've been losing that voice. We pay lip service to it, so when we redesign a building, we have a patient group. When we have protocols, we have patient and family support groups to tell us what a lousy job we were doing. And the 3 patients who either happen to be our donors or who had the best recovery tell us a little bit better how to do it. This is all of our patients telling us in an ongoing way how to do a better job, to use the same kind of work that we're putting together in data warehouses to be able to inform that. These data become real time and inform the process in terms of our outcome. And this is a way in which we can tell the marketplace that we are being accountable. This clearly, the more that we can make this easier for our providers, the more that we're not just adding a pile of data or not making this connected, the better the opportunity is for this to be adopted, because we're putting so much on our providers. We're transforming the care that we provide. We're changing their income streams. We're changing their incentives. If we don't do this in a way that's thoughtful, that helps them to grow, we will fail. And if we have our patient's voice, at the end of the day, we are so much better. This is the real telemetry of the future. Thank you very much.